Hello and welcome everyone. Today's presentation is acute dyspnea in emergency department. This is one of the most common presentation in patients coming to emergency. Dyspnea encompasses various uncomfortable breathing sensations such as air hunger, effortful breathing and chest tightness. The perception of dyspnea is affected by social, cultural and psychological aspects. It is a major cause of emergency department visits associated with various diseases like cardiorespiratory, infectious and oncological conditions. The severity of the dyspnea upon ED arrival can predict the need for hospital admission. It's linked to longer ED stays and higher in-hospital death rates. Physicians face the challenge of quickly diagnosing and deciding on the treatment plan with very limited information. Prompt and accurate treatment, especially the differential diagnosis, is crucial in saving lives and reducing the hospital mortality and the stay duration. The pathophysiology. The most common pathophysiology is hypercapnia or hypoxia. Hypercapnia is increased arterial PCO2, directly causing breathlessness, challenging earlier beliefs that it only affects dyspnea through reflex of the respiratory changes. The next is hypoxia. While mild hypoxia can intensify hypercapnia-induced air hunger, significant hypoxia is required to trigger dyspnea on its own. In healthy patients, air hunger occurs when the arterial oxygen pressure drops below 60 in absence of an increased PCO2. Now, conditions such as ARDS, chronic obstructive pulmonary disease, asthma exacerbations, acute heart failure can lead to acute increase in PCO2, contributing to the dyspnea. The next is mechanical loading. There can be an increased work of breathing. This is dyspnea which arises in situations where the respiratory muscles face an increased resistive load or when the ability to generate the pressure is compromised due to weakness or mechanical disadvantages like hyperinflation in COPD patients. Now, dynamic hyperinflation and tidal expiratory flow limitation, which is common in COPD, exacerbation, it flare-ups, reducing the hyperinflation through interventions can elevate the dyspnea. In heart failure, orthopnea and dyspnea experienced when moving from standing to supine can be linked to this dynamic hyperinflation. The next is activation of the pulmonary receptors. Dyspnea is a condition like pulmonary fibrosis might be due to the activation of the vagal afferents from inflammation. This mechanism can also contribute to dyspnea in other pulmonary conditions involving congestion, mediator release, or tissue alterations. Pulmonary thromboembolism can cause rapid onset dyspnea, which can be a solitary symptom in pulmonary embolism, may arise from activation of the pulmonary receptors and is often disproportionate to the gas exchange abnormalities. Now, asthma can also give a sensation of chest tightness and constriction, often reported due to linked activation of the irritant receptors. So, to summarize, the common causes are there can be a problem in the gas exchange, or there can be a problem in the mechanical aspect, that is, you can have a effusion or weakness in the muscles or some chest wall abnormalities which can cause the mechanical problem, or you can have receptor pulmonary direct pulmonary receptors causing a dyspnea feedback to the neurogenic center, causing increased work of breathing. The next is diagnostic evaluation. First is definitely the clinical presentation, which is the self-reporting nature. Dyspnea is a subjective experience and must be assessed distinct from the observable signs of respiratory distress like a tachypnea or the use of accessory respiratory muscle. Now, observation of respiratory sign. Despite its subjective nature, the presence of the physical signs such as tachypnea or accessory muscles should be carefully seen for diagnostic accuracy. Respiratory rate should ideally be observed over 60 seconds by watching the chest and abdominal movements. Normal range is 12 to 22 regardless of the age. An increase can indicate respiratory or non-respiratory disease and is critical in acute care evaluation like the quick SOFA score for suspected sepsis. The next sign is tachypnea. Persistent high respiratory rate can signal respiratory failure, neuromuscular disease, or acute pulmonary or extrapulmonary restrictions. Next is breathing pattern. A rapid, shallow breathing pattern that is difficult to assess in spontaneously breathing patients. Hypopnea, that is increased tidal volume or frequency, could be due to metabolic acidosis or conditions like diabetes mellitus, renal failure, or rhabdomyolysis. Here, the patient may not primarily have a respiratory disorder, but here the patient takes very deep and large tidal volume breaths. There can also be increased work of breathing, which is signed by suprasternal fossa recession, a tracheal tug, or inward motion of the lower ribs, suggesting hyperinflation. Other indicators are sternocleidomastoid activation during inspiration, occipital dorsiflexion, nasal flaring, opening mouth, and inspiratory laryngeal groans. This is very important signs. You must look for these signs to see if the patient has increased work of breathing. The next is biomarkers. Once you have done a clinical assessment, and from your clinical assessment, you have an idea that this is the possible type of pattern of dyspnea that the patient is facing, then the next thing that we look for is the blood biomarkers, and the most important in dyspnea is the arterial blood gas. The key measured here is the oxygen and the carbon dioxide level. Rapid evaluation of the blood pH, PO2 and PCO2. The pH value at presentation is linked to patient outcomes, with a pH of less than 7.39 associated with higher mortality after 12 months. The recommendation is essential for all acute dyspnea cases in emergency for initial assessment and ongoing monitoring in certain conditions. So, any patient coming with dyspnea, it is recommended to do a ABG. The next biomarker is B-type natriuretic peptide. It differentiates cardiac from pulmonary causes of dyspnea. The threshold value of more than 100 BNP or more than 300 NT-proBNP suggests an acute heart failure. Now, plasma levels can be influenced by age, kidney disease, atrial fibrillation, and obesity, affecting the diagnostic accuracy. So, it is not something which is recommended to be done in all cases, but if you have a doubt of acute heart failure and you think that the diagnosis of acute heart failure is going to change your management, then probably you can send the blood for BNP. The next is chest x-ray and ultrasound. These are very, very important things. Chest x-ray is the mainstay and should be done in all cases. The standard initial management in dyspnea, crucial for diagnosing important conditions like pneumonia and pleural effusion. The limitations is the possibility of false negative and variable interpretation agreement between the ED physician and radiologist. Because chest x-ray is a very subjective finding, there are a lot of different interpretations and subjective variations. And it also can give false negative results where the patient can be very, very dyspneic and having a pulmonary disorder, but the x-ray comes out to be normal. The next is pneumothorax and pleural effusion, which can be diagnosed and quantified in chest x-rays. The next is to see for cardiac causes. Pulmonary venous congestion, cardiomegaly, or pleural effusion can indicate a cardiac origin, but around 20% of heart failure admissions might have a non-diagnostic chest x-ray. Next is ultrasound. Cardiac ultrasound, established value in ED, supported by numerous guidelines, and probably should be done in all cases, especially if you're suspecting any cardiac disorder. Lung ultrasound, it is slowly gaining recognition, and it's something, if present, should be used in all cases. Advantage of lung ultrasound over X-ray is it is high sensitive for conditions like pleural effusion. In some cases, lung ultrasound combined with the echo offers rapid and accurate assessment, surpassing standard care. You have various protocols. One of the more commonly used protocol is the Blue protocol, which utilizes the lung ultrasound to differentiate causes of acute respiratory failure by identifying signs like lung sliding, A lines, and B lines. Now, key points for dyspnea evaluation are lung slide and A-line, the exclusion of interstitial edema, lung consolidation, pleural effusion, and pneumothorax can be done by this. The next is B lines. This shows an interstitial syndrome which is associated with various conditions like fibrosis and pneumonia. This basically indicates that there is some fluid accumulation inside the lungs. Integration with echo increases the accuracy because it helps us in identify cardiac causes. Pre-hospital triage, chest ultrasound is becoming valuable for pre-hospital diagnosis and care, improving the intervention appropriately. Despite its benefits, the variability in the studies and lack of standardization has led to cautious endorsement of bedside ultrasound as an objective tool for acute dyspnea in ED. However, its use is likely to expand with further research and standardization. Chest CT, gold standard, essential for diagnostic conditions like pulmonary embolism and lung malignancy, with CT pulmonary angio being crucial for pulmonary embolism diagnosis. While lung ultrasound is emerging as a useful tool, societal guidelines still prioritize chest X-ray and CT for diagnosing pneumonia and pneumothorax due to established efficacy and sensitivity. So this slide basically gives us a brief idea regarding the ultrasound and its findings. So these are the normal findings. This is a normal lung where you will find the lung sliding over here. The pleura will be sliding, the glistening structure as the pleura will be sliding over here. You have A lines. You will have reverberating lines from the lungs. Then the vertical scan will have less than 3 B lines going on. In the M mode, you will find a seesaw appearance. You will have this straight lines, and once it enters the lung, you will have this dotted type of appearance in M mode. So what happens in pneumothorax is this dotted line goes away, and the same straight lines are seen. This is called the barcode sign. And you will also have the absence of the lung sliding because the air is between the pleural cavity now, so you will not find the pleura sliding over each other. The next is consolidation, where you will get a hepatic like structure of the lungs, which will help you in making the diagnosis of a pneumonia. You can find air bronchograms also. Pleural effusion is something again which is commonly seen. You will clearly see a fluid in the pleural cavity with a collapsed lung. This is a complicated effusion where you are seeing other echogenic structure inside the pleural cavity. In the interstitial syndrome, if there is pulmonary edema, you will see a lot of B lines, as we have said before. This is showing basically the fluid accumulation in the alveolus or the interstitial space. So you will find more than 3 such lines radiating vertically from the pleural space. Regarding the inflammation and fibrosis, you will find a lot of pleural irregularities, subpleural consolidations, and artifacts. In lung contusions, multiple confluent vertical artifacts with no suspicions of cardiogenic pulmonary edema can be seen. This will indicate a lung contusion. Finally, apart from the lung, you can also access the diaphragm, where you can see the normal diaphragmatic excursions, which may be absent in cases where there is a neuromuscular disorder, or in severe cases of COPD, where there is a lot of air trapping and the flattening of the diaphragm has occurred. Now, once you have done all this assessment, then you can go for the management. Non-invasive respiratory support like HFNO, CPAP, NIV are crucial in managing this disorder in emergency. These methods aim to improve the gas exchange, reduce dyspnea and work of breathing, and prevent the need for intubation and invasive ventilation along with their associated risks. The benefits is gas exchange improvement, enhanced oxygenation and CO2 elimination, dyspnea elevation, reducing the sensation of breathlessness, reduce the work of breathing because you're giving a positive pressure and the ventilator is doing the lot of work of breathing. Then you have hemodynamic effect. The non-invasive support also positively affects the heart function, especially by changing the left ventricular afterload. Now the concerns. P-Cili is a very important concern. The hypothesis suggests that very high inspiratory drives in this patient can cause very large intrathoracic swings, which can cause P-Cili. So in this, what you have to note is if you are seeing the patient is taking very high tidal volumes and is extremely dyspneic, and this continues despite you putting the patient on NIV, that is, if the respiratory rate is still high and the tidal volumes are still high, then there is a very high chance that the patient is going to develop a patient self-inflicted lung injury, especially when we are giving a positive pressure through non-invasive ventilator. Patient selection is vital. Success heavily depends on patient selection, continuous physiological monitoring of the patient. This is the reason why you need to continuously monitor the patient. Once you have attached, you have to continuously monitor the patient over the next 15, 30 minutes and 1 hour. Because if there is a progressive improvement, then only the patient is likely to benefit. If you are not seeing significant improvement, then the need for invasive ventilation becomes very, very crucial over here. Timely transition to invasive ventilation is very, very vital, because with all this monitoring and everything, if the patient is still not showing improvement, the more delay we do with putting the patient on invasive makes the patient worse over time, because the patient has a disorder, and with the P-Cili, the disorder is only going to go worse. Now the application in acute cardiogenic pulmonary edema. You can go with CPAP and NIV, demonstrated to be superior to conventional oxygen therapy in improving various cardiopulmonary physiological parameters, reducing the respiratory rate, work, and dyspnea. Both CPAP and NIV show similar effectiveness in enhancing pulmonary and cardiovascular function. However, NIV might offer additional benefits in unloading respiratory muscles and improving gas exchange, especially in patients with pulmonary edema and acidosis. Concerns about increased acute myocardial infarction risk with NIV have not been confirmed in large studies and meta-analysis, indicating that the safety of this non-invasive strategy cannot be told. While many studies show reduced intubation rate with CPAP and NIV, evidence on the impact of hospital stay mortality is mixed. Nonetheless, meta-analysis suggests a survival benefit, leading to recommendation on the use of acute respiratory failure due to cardiogenic pulmonary edema. So for all practical purposes, initially, if the patient is diagnosed as having a cardiogenic pulmonary edema, please use CPAP or NIV. It is going to be beneficial to your patient. HFNO can be used, has been shown to reduce respiratory rates, but no significant impact on intubation or mortality. When compared to the CPAP, has lesser improvement, possibly due to lower application of PEEP. So for all practical purposes, HFNO can be used in less severe patients, where I think that only giving a large oxygen load will benefit, or the patient doesn't have a very high need of PEEP. Now coming to hypoxemic respiratory failure of non-cardiogenic origin. In this case, it is not related to the heart condition, and it is more related with some infective etiology or pneumonia. In meta-analysis findings, non-invasive ventilation strategies and HFNO are linked to reduced intubation rate and lower mortality rate compared to standard oxygen. The mortality benefit of face mask NIV diminished when excluding COPD and heart failure patient, but remains with the helmet NIV. Now, evidence is limited and mixed, making it hard to determine the best non-invasive mortality for managing hypoxemic ARF. The guidelines currently have very few directives in choice of ventilatory support for hypoxemia due to low certainty of evidence and high risk of bias. Decisions often rely on the clinical judgment of experienced physician, considering the specific circumstance and patient's need. The impact of COVID-19 pandemic with increased reliance on non-invasive ventilations due to urgent need and scarcity of resources has shown that despite widespread use, outcome in terms of intubation rate and mortality rates have varied greatly, influenced by differences in the patient population, disease severity, and treatment protocols. So again, for practical purposes, in hypoxemic respiratory failure, if the patient is again very less dyspneic, then you can go for HFNO. But if the patient is having severe dyspnea, it is better to go with NIV. But here you need to be very, very careful, much more careful than you were there in cardiac cases or COPD cases. Here the chances that the patient is not improving is very, very high. If you do not see a improvement, then it is better to intubate these patients early rather than putting them too long on non-invasive ventilatory support. Now, management of acute hypoxemic respiratory failure with non-invasive strategy. Coming back to CPAP. CPAP supports the alveolar recruitment, lung expansion, and can improve gas exchange, potentially reducing the lung injury from cyclic opening and closing. Helmet CPAP has shown to reduce intubation rates in severe hypoxemia due to pneumonia. However, effectiveness in unloading respiratory muscles and relieving dyspnea might be less than NIV. Next is NIV. NIV can lead to quicker and greater enhancement in respiratory rate and oxygenation. Some studies suggest benefits like shorter ICU stay, reduced intubation rates. Challenges are success hinges on avoiding delayed intubation for NIV failure, which is linked to higher mortality. The predictors of NIV failure include the severity of disease, shock, and certain ARDS conditions. Now, the choice of support pressure, PEEP level, and interface is crucial. Helmet can reduce side effects, provide similar oxygen benefits to the face mask, with some studies showing better outcomes. HFNO. HFNO offers benefit with reduced nasopharyngeal resistance, dead air space washout. Now, it is generally more tolerable, potentially improving patient comfort and treatment adherence. While HFNO has shown promise, especially in COVID-19, its impact in mortality is still unclear. Further large trials are definitely needed in this population. Now, coming to acute hypercapnic respiratory failure of non-cardiac origin. Here, NIV is cornerstone, and this can be because of COPD, obesity, hypoventilation, neuromuscular disorders, and it has been quite beneficial by reducing intubation rates. Key indicator for NIV especially is respiratory acidosis. Early NIV can improve survival, reduce hospital stays. Not a contraindication of NIV, especially if the patient is in coma, because using the NIV may lead to improvement in the consciousness and patient may come out in some 1 to 2 hours. NIV can benefit some patients by stabilizing the airways and improving FEV1, but its superiority over standard therapy isn't quite proven. In the overlap syndrome, it can be used cautiously with expert guidance. Regarding the neuromuscular diseases, NIV is a standard for chronic support, but evidence for acute intervention is limited. Patients without bulbar involvement may benefit from trial. So this is very important. If your patient is having any kind of a bulbar palsy and the patient is getting dyspneic, please don't put the patient on NIV. It is better to intubate. Or if the patient is having acute neuromuscular disorder, then please again don't put the patient on NIV. It is better to put the patient on ventilatory support, invasive ventilatory support. Obesity, hyperventilation, positive outcomes, and it should be used. HFNO role in hypoxemic failure is recognized, but in hypercapnic condition it is less useful. And current studies in hypercapnic failure are limited, and we need more studies for HFNO use. So to summarize, when a patient comes with acute dyspnea, first do your clinical evaluation, check the respiratory rate, which you do for 60 seconds, sign of respiratory distress, look for tachypnea, hypopnea, rapid shallow breathing, activation of the accessory muscles, sign of increased work of breathing should be noted. All these signs are important, and if you find any such sign, please be sure that the patient needs ICU support or respiratory support. The next is biomarkers sent for ABG, BNP, drop-I, D-dimers. Now this thing you must keep in mind that once you have seen this, and if the patient is very, very bad in your clinical evaluation, don't wait for your ABG to start a respiratory support. If the patient needs respiratory support, kindly give the respiratory support and then set ABG. You don't need to see a bad ABG for intervention. The clinical evaluation is more than sufficient. Next, after blood gas, is imaging, where you do a ultrasound, check the heart and the lungs, do the chest X-ray, and in rare cases you can do a chest CT also. Regarding the management, as we have clearly discussed, in hypercapnic, go for NIV. In cardiac origin hypoxemic, go for NIV. You can use BiPAP in all these cases, or you can use HFNO in all these cases if the patient is less severe. And regarding hypoxemic, it is better to go for invasive, but you can try with NIV, but be very, very cautious and always keep monitoring the patient. If you find any signs of non-improvement or continued dyspnea, then kindly intubate the patients. Thank you for your patience.